We start off with introducing our very dear Dr. Pravin Krishna, who is the network director and also is the director of the Cornea Institute of Excellence of LV Prasad. And as I said, I meant it from the depth of my heart, best for the last. But I shouldn't say it too often because the other speakers were too good too. So he's going to be talking to us on DMEK in challenging situations. On to you, Dr. Praveen. It was really not in our agenda to keep you as the last speaker, but I think keeping you as the last would have all those people waiting for your talk.
Thank you, Shreyas and Chitra, and everyone else for putting together this very nice meeting. So what I'm going to do in my talk, which is supposed to be about special situations in DMEK surgery, is I was thinking for the last few days on how to put together a talk for 10 minutes about special situations. And then I was scratching my head. And then I decided that it's not possible to do that because special situations in DMEK by themselves, each of them probably is like a 45-minute or a 1 hour kind of a workshop, probably even longer. So what I thought is I'll just give you a flavor of each of these challenging situations with one take-home point each, so that if there is a requirement for a longer discussion or maybe a future talk about any of these areas, we could probably dive deeper into them. So what I'll do is I'll talk about primarily 5 challenging situations, if time permits, maybe a sixth. First is about poor visibility during DMEK surgery. Second is dealing with irregular surfaces during DMEK surgery, especially the posterior surface. Then about unstable IOLs. Then about shallow chambers, deep chambers, and then interface fluid, along with endothelial dysfunction as well. We'll try and just give a case examples of each of these and try and see what is it that we can learn. The first situation is poor visibility. Again, there are a number of scenarios that you can have poor visibility in. But the reason why I chose this is the fact that this is a failed DSEC. And the reason why I chose this is because this is probably one of the ideal cases for DMEK surgeons who are at the beginning of their learning curve to pick these cases for their first few DMEK surgeries. The reason is these are patients who have relatively poor vision, and once you strip the DSEC graft off, the visibility actually improves very, very significantly. So you have a patient who has probably slightly lower expectations, but you also have a cornea that has relatively good visibility once you take the epithelium and the DSEC graft off. Here is an example of a video that I'm actually going to show what happens when you take off the DSEC graft and the epithelium. Are you able to see my video? Is it moving?
Yes, it's moving.
Fantastic. So once you take the epithelium off, the visibility does improve. And then once you take the DSEC graft off, in fact, the visibility improves to almost have a clear cornea. So these are the ideal kind of cases that you would like to try DMEK in. And here you go. That's the DSEC graft coming off. And you will see that the added advantage in this case is the fact that the iris is also light colored. And so the blue DMEK graft against the light colored iris also stands out really well. So this is the ideal kind of situation to have when you're doing DMEK in your early cases. So I'll just let this run for a few seconds. Here you see actually that I've also marked the DMEK graft, which is another thing that you should do as surgeons who are beginning. All of us don't have an IOCT, so the mark actually helps a lot in confirming what is the correct orientation. And if you know that the lenticule or your DMEK graft is in reverse orientation, then you can spend some time trying to ensure that it's in the right orientation. And most of the time, once you understand the fluid dynamics and also know how the graft will move inside the eye, after that, handling it and opening it is no great shakes. It actually is relatively easy to understand how to manipulate the graft. So this is post-op day 3 of the same patient, and you'll see that the cornea is already quite compact and quite clear compared to how it is looking preoperatively. Same patient 2 months later, and his best corrected visual acuity is 20/30. And you saw the difference that a DMEK makes in a cornea that is not clear. The other very important, I think, tip in patients where you have relatively poor visibility or you're not able to make out what's going on, in addition to making a mark, I make a P mark as you see here, is to have what I call the poor man's IOCT, which is the light pipe during surgery. Because once you make a mark, and sometimes if you have a very dark brown iris like you have down here, you might not be able to make out the mark that you printed on the cornea. Instead, if you use a light pipe, you'll be able to see the mark much better. Here you can see it like a 9, and that will help you to also manipulate your graph in the correct orientation. And once you get it in the correct orientation, then once you stick it, then it's much easier to see. So the light pipe is it doesn't cost a lot of money, about $1.5 lakh to get a light pipe system along with a light pipe, and it's very useful to identify orientation in DMEK. Second scenario is irregular surfaces. Again, this is something that I probably learned the hard way. If you have a post PK patient where you have poor visibility in the graft host junction and you're doing a DMEK, this is a post DSEK eye. So I'm taking off the old DSEK graft, hoping the visibility will improve. And I'm trying to do a DMEK. This patient also has a tube. So he has multiple comorbidities. You see that there's a tube here and he also has Seneca. So I'm trimming the tube before I put my DMEK graft inside. So at the end of this, I'll also give you another tip that I think I follow nowadays. So the surgery went off relatively, easy in the beginning. But once I started trying to manipulate the graft and try to inject an air bubble, in fact, I had some bleeding and I was able to handle that as well. But the tip here is the fact that if you have a very dense graft host junction, what is very important for you to do before surgery is to do an OCT, because as you can see in this picture, there is edema on the side of the graft. And when I do an OCT, I'll see that there is a very prominent graft host junction, which is not going to allow your DMEK graft to attach whatever manipulation you do inside the eye. So if you have a very irregular and a prominent graft host junction on the posterior surface, you should be able to predict this with an OCT. And in fact, cases like this, probably the ideal surgery to do, going back to what Dr. Revati said, is probably to do a PK. Because even if you do a DSEK or a DMEK, DMEK is very tough because you'll have to use a very small graft. DSEK as well, you'll be implanting very few endothelial cells. So it might be a good idea to do a PK instead of a DMEK or a DSEK. Now, coming to the third scenario, which is shallow chambers or ice syndrome. Here is an example of a patient, youngish patient with Chandler syndrome, extensive PAS, as you can see all around. The OCT of the angle, this is the OCT that shows that almost all his angles are closed off. So I'll show a very brief video just to show you the synucleolysis and why it is very important to do this step. Because this step is how you convert a shallow chamber into a deeper chamber. So initially, I'm putting an air bubble inside the eye, and you'll see that the air bubble actually breaks up and also doesn't really fill up the entire anterior chamber. It only goes somewhere up to like the mid periphery, and that is the amount of space that is available inside the anterior chamber. So putting an AC maintainer and then doing a meticulous synucleolysis is what is going to create space for you in this patient to be able to do DMEK surgery. And after I do a complete synucleolysis, has to be slow because you don't want a lot of bleeding as well, because bleeding is going to lead to fibrin. Fibrin is going to lead to difficult unfolding of your graft. And this is where the AC maintainer is very important because it will continue to remove any blood from the eye and doesn't allow fibrin buildup. Sometimes the Synekia also pulls off the Descemet's membrane. And so it's very important to go in and smoothen the iris. Otherwise, your graft will not have place to move. So this is what I'm doing. I'm trying to shave off the anterior surface of the iris, which has parts of the Descemet's membrane stuck to it before I put my graft inside the eye. And this is really important because if you don't do this, then your graft will get stuck. It's not going to move. It's not going to be able to open around. You can even use a retractor to do this. So this is the DMEK being done, and I won't show you the entire sequence. It is relatively quick. But what I want to show you is the size of the air bubble. And you see this is an air bubble that is placed inside the eye. and you see that you can't see the margin of the air bubble because it's gone completely into the angle because of the Sanicae that were released. Same patient, post-op day 7, really clear cornea, almost no Sanicae as you can see. Same patient, post-op day 30, doing really well. Phakic young guy, about 27, 28-year-old chap, and very good endothelial cell count as well after DMEK surgery. The same kind of scenario also occurs very commonly after cataract surgery in patients who have TAS. You have a fixed dilated pupil, plenty of Sanicae in the periphery, and sometimes CME as well because of the inflammation post-op. These patients also the same approach, meticulous saniculisis. You need to be a little careful of the dilated pupil, but you can do DMEK. They do tend to have some amount of posterior stromal scarring, as you can see here, because of inflammation in the posterior stroma, but they usually have relatively good visual recovery. Fourth scenario, deep anterior chambers. Again, this is not something that I would recommend that you do right away. And this is again one of those showboating kind of videos that I'm going to show you just to show you what can be done. So this is a case where I have a ACIOL. This is about, I would say, six years ago or so. ACIOL that appeared to be small. So what I did was I did a vitrectomy, did ACIOL exchange. And after that, I put in a contact lens, a prosthetic contact lens to actually serve as a template on which I could unfold my DMEK graft. Now, I probably would just take off this ACIOL and put an iris law lens, or maybe even ask my retina colleagues to do a glued IOL. I don't do a glued IOL myself. But then this was the time of potential youth in the DMEK world. So that is when we want to do DMEK on everything. And so I thought I'll do something different. And here, what I'm trying to do is trying to fold white prosthetic contact lens into the anterior chamber, insert it and unfold it so that it actually prevents the DMEK graft from going posteriorly, also shallows the anterior chamber, and in addition, gives us a fantastic visibility of the DMEK graft or the blue DMEK graft against the white lens. So I'll forward this and you'll see that this is where the DMEK graft is being injected. And you'll see that visibility is definitely not a problem here. You can see the DMEK graft really well. The AC is relatively shallow, so the graft also behaves itself. It is not touching the IOL, though it might be touching the BCL. And eventually, I will get this to unfold. And I actually get it to attach to the cornea. And once I get it to attach to the cornea and unfold completely, then I can go in and remove the bandage contact lens. So I'm just removing some of the fluid, some of the air with the fluid after the graft is attached for 10 minutes. And then I'll go in and I'll take off the bandage contact lens. You can also cut the bandage contact lens and take it. In this case, you saw that the contact lens was actually touching the graft in one area, which is not very desirable. Same patient, post-op day 7, showing that the patient did really well. And this patient also has about a year and a half follow-up before I lost follow-up for this patient, but did pretty well, had a decent amount of endothelial cell loss, not unusual from what I would expect, but I thought that was a good technique, except it was too time-consuming. Here is another scenario where you can also do the same kind of surgery in a patient. This is a patient with an ICL who had a corneal decompensation and needed a DMEK surgery. If you remove the ICL to do the DMEK, then you have a very deep anterior chamber. So actually surgery is tough. But if you keep the ICL, then you have a very shallow anterior chamber. So you actually have a dilemma of what you want to do. So I decided that I'm going to keep the ICL and do the DMEK in the shallower chamber because that's where I would prefer a shallower chamber than a deeper chamber. Again, won't bore you with the surgical details, but then this patient did really well from the point of view of the outcomes. And we were able to do a DMEK graft. This is just the surgery and showing you the DMEK attachment post-op. The last scenario that I would like to share with you is an interesting one where we were faced with patients who came in with interface fluid in a patient who had LASIK surgery. Normally, after LASIK, if you find that the pressure is high, that is when you'll find interface fluid. And also, you expect that once the pressure normalizes, this tends to go away. But then we had a patient who came in with IOP completely normal, but with interface fluid. And then when we saw that there was a massive cleft in between the flap and the stromal bed, OCT revealed the fact that there was a fluid cleft that was lined by epithelium. You can actually see the epithelium in the fluid cleft. And the posterior stroma also had quite some edema, and the Descemet's membrane was also quite thick here too. So this patient was a patient whose other eye revealed that she had Fuchs dystrophy. She had LASIK about 10 years ago. And then after the LASIK surgery was done, she was doing very well, but once she decompensated, then she had this interface fluid. So what was interesting here was that we had to operate in two different planes, right? So we had to first lift up the LASIK flap and evacuate the fluid that was there in the interface. And also the epithelium that was lining that LASIK flap on both sides, that needed to be removed quite meticulously as well. So this is me trying to open up that epithelial cyst, and you will find that it's actually quite fibrosed. And once I enter it, there'll be a gush of fluid. And again, for lack of time, I probably won't show you the entire video, but then this is the more interesting part about how you actually open up the LASIK flap and how you ensure that all the fluid is removed. In fact, the flap was so adherent that in one area we had to use a crescent knife to slice it open so that it actually has a clean cut rather than just rip it open. And all of this is the epithelium. And the epithelium, we again rubbed it off, and then we used alcohol to ensure that there is no epithelial cells that are left behind. So it is quite a long surgery. In fact, this took longer than the actual DMEK. Once that was done, then the underside of the flap, and then we did the DMEK like you would do in any other normal case. And the DMEK did very well as well. And we used a roller. This is post-op day 3. Interface fluid came down significantly, but there was still some interface fluid. Post-op 9 months, she did really well. Vision recovered to 20/20 with correction, and she's really happy after the surgery at this point of time. Good endothelial cell count as well. So this is post-op and this is pre-op, show you the stark difference. And one last similar scenario that we faced was another patient who came with the same kind of a problem, a LASIK flap, a cataract, uveitis, and also glaucoma. And this was a patient who had one of these infernal cosmetic iris implants in her eye. This is the eye of a sibling. She had her implant removed because of inflammation and glaucoma just before she came here, but her cornea decompensated. But she also had the same kind of interface fluid syndrome. So we were able to eventually operate her, did a DMEK and put the flap and removed all the epithelium in play from the interface. She did pretty well. She developed secondary glaucoma, required a trab, then a tube, and now is just hanging on for dear life with the DMEK still doing pretty well about 2.5, 3 years down the line as well. So just to, that's the OCT. Just to summarize the challenging situations that we went through today, poor visibility, ensure that you take off the epithelium and take off any other intervening structures like a DSEK graft that will improve visibility. Use a light pipe to ensure that visibility is better. If you have irregular surfaces like a post-PK, make sure you do an OCT before you take them for patient for surgery. Sometimes doing a PK might be better than DMEK or DSEK. Unstable IOLs are potentially best exchanged because the surgery in DMEK is also going to be shallowing and deepening the chamber quite a lot. If you have a shallow chamber, surgery is still possible, but spend time to ensure that all the synechia are removed so that you create space for yourself. If you have a very deep chamber, potentially now, I would say that very deep chambers, DSEK is better choice than a DMEK surgery, but you can use that prosthetic CL trick that I showed you. When you're in your early part of your learning curve, you're gung-ho and you have a lot of energy, maybe you'll do that. But later on, you want surgery to be quick, easy, and also uncomplicated. Probably I won't do it now. And if you have interface fluid, again, the interface fluid might be because of endothelial dysfunction. So the answer might not just be draining the fluid, but also ensuring that you replace the endothelium. Thank you very much for your kind attention.
Thank you very much. That was an awesome talk, Dr. Pravin. So what I would ask before Shreyash takes on is, can you tell me when you would not do a DMEK? Or rather, with your kind of experience, when would you do a DMEK or when you would do a DSEK?
I think 3 simple rules rather than go through scenarios. I think where making a choice of doing a DMEK is not going to benefit the patient from the vision point of view. Like, say, somebody has maybe retinal pathology or maybe has poor visual potential, then taking the extra effort to do DMEK probably doesn't make any sense. I think number two is where the disorganization in the anterior chamber is so much that the extra manipulation that I'll need to do for DMEK is going to result in more endothelial cell loss, rather than do a quick, easy DSEK, which will result in less endothelial cell loss. I think is the second scenario. I think in those cases, DSEK do better as well as compared to DMEK. Third is where I expect there to be a challenge with maintaining air bubble inside the anterior chamber. Somebody with a vitrectomized eye where I can't maintain position and things like that, I think is the third scenario. I wouldn't do DMEK, I would do a DSEK. Earlier, when DMEK came about, people thought, oh, DSEK is going to disappear, but that's not true. DSEK very much has its place and probably is better than DMEK in some scenarios like this.
Suresh, on to you.
Wonderful, sir. I mean, beautifully summarized, and I think the situations, the videos, it was truly entertaining and lovely to watch as always. Quick question, sir, regarding the sizing that you did in some of these cases where you released all the Sinike. I mean, it was very nice to watch, but very often these Sinike do tend to come back. And while it may not really pull off a DSEK graft with a DMEK, that might be a little bit more of a concern. Would you really undersize the DMEK graft in those sites?
I mean, that's a great question. And interestingly, I just want to show you a quick slide because what we did was we, in fact, published this in Cornea, I think last year, 2 years ago, with the hypothesis that DMEK potentially prevents Sinike from coming back as compared to DSEK. And this is the same patient that I showed you today over a 4-year period of follow-up. And you'll see that there is some distortion of the pupil that is happening and some peripheral Sinike, but the majority of the Sinike actually have not come back. And so the hypothesis that we put together in the paper was because eye syndrome is also abnormal endothelium that grows, epithelioid kind of transformation that grows on the iris and on the angle and the cornea and causes the Sinike. If you have good endothelial cell counts and your DMEK graft endothelium actually migrates peripherally, then that probably will prevent the influx of this epithelial endothelium towards the center and maybe retard Sinike. Because we don't see that with DSEK. DSEK also Sinike form very quickly, but it seems that DMEK might have some mechanism in preventing Sinike from developing.
So, does this apply only for eye syndrome, or you would do it even for a failed graft with peripheral anterior Sinike?
I don't know if it actually works for those scenarios. For eye syndrome, it seems to be pretty predictable, but others I'm not very sure about.
Wonderful, sir.
Thanks, Shreyas. Nice to see you.